Hi, it's Jamie Batts, your instructor for A&P2. We're going to continue on with our lecture on the digestive system. We were just finishing up talking about the function of liver tissues, Kupffer cells, and the sinusoids. And now we're going to get into some of the other accessory organs of the digestive tract, including the pancreas and gallbladder. Let me switch here to screen share mode so you can see what I see. And the gallbladder is closely associated with the liver, right? It's just located on that posterior side of the right lobe of the liver. It has three regions, a fundus. Whenever you see that word fundus, just like on the stomach, it is this kind of extended upper portion. Then there's the body and the neck. So it's kind of like an upside down pear almost. It stores and concentrates the bile. The bile, of course, is secreted from the liver. It passes into the gallbladder and through the cystic duct, and then out of the gallbladder through the cystic duct as well. The cystic duct's kind of like a two-lane highway. Those bile salts that are secreted from the gallbladder function in the emulsification and breakdown of lipid particles in our digestive tract. So basically what it does is it allows for an increased amount of surface area on the outside of the lipid so that the enzymes can really chomp down and digest that lipid and break it down into its smaller pieces. Lipids, remember, are very long, very large hydrocarbon molecules. So the bile just helps to allow for more enzymes to get in there. So the right and left hepatic ducts are collecting the bile from the liver bile ducts, and then the hepatic ducts form what's called the common hepatic duct. The common bile duct is one of the branches from the common hepatic duct, so as well as the cystic duct. So what I would do if I were you is take the information on this slide and create a sequence chart of it. So you have right and left hepatic ducts fusing together to form a common hepatic duct. The common hepatic duct branches, and you have the common bile duct that's going down to the duodenum and the cystic duct that's going to the gallbladder. So the cystic duct, when needed, can actually push and remove bile back from the gallbladder. So again, the cystic duct is kind of like a two-lane highway into and out of the gallbladder. It fuses back in with the common bile duct to go into the duodenum during the digestive process. So when the common bile duct, where it goes into the duodenum, is at an area called the duodenal ampulla, which is just a little area right where that pancreatic duct fuses as well. So there's two little ducts that fuse together in this ampulla, which is an opening. There's a sphincter muscle there. It's called the hepatopancreatic sphincter, and this encircles this lumen and controls the output of bile as well as pancreatic juices. This is all controlled through CCK and secretin, namely CCK. That hormone that we mentioned earlier. So here you see all of our bile ducts. You see that cystic duct coming and branching off of our gallbladder, the right and left hepatic ducts, common hepatic duct, and then the common bile duct. So the common hepatic duct basically changes names, so to speak. It goes from the common hepatic duct to the common bile duct. Follow that common bile duct down into the pancreas, and you can see it fuses with the pancreatic duct, which is the duct leaving the pancreas, and opens into the duodenum via that duodenal ampulla. So there is a functional relationship between bile storage and bile ejection. The liver is producing about 1 liter of bile per day. Think about that's a lot, right? Unless that hepatopancreatic sphincter is open, the bile is just going to go right into the gallbladder for storage. This is all, again, controlled by CCK. CCK is going to trigger that dilation of the hepatopancreatic sphincter, allowing for the gallbladder to contract and bile to be ejected into the duodenum. Here you see the overall flow chart. And again, you can take like note cards or even Post-its and create, put them in order and see if you can, jumble them up and sequence them, or you can create your own flow chart from this page. So the liver secreting bile continuously as it remains in the gallbladder. The bile is just going to become more and more and more concentrated. When CCK is released, that will release and relax the hepatopancreatic sphincter, allowing for the lipid droplets to be emulsified and therefore broken down more completely. Let's talk about the pancreas. The pancreas is actually retroperitoneal, which means it's behind the peritoneal cavity. It's not surrounded by mesenteries, and it's just behind the stomach. It is lateral to the duodenum. It kind of nestles in there. It looks like a little fish, kind of leaning in on the duodenum. It's slender, and it's pinkish and gray. In fact, on most cadavers, you will not be able to find a pancreas. The reason is because as the body is breaking down and metabolism is stopped as all the cells are beginning to die, the pancreas is literally digested by the enzymes that are inside of it. The pancreas contains many, many, many enzymes that aid in digestion, including nucleases, lipases, proteases. Those are all the special enzymes that are breaking down the nutrients in the food. So, the hepatopancreatic sphincter is the route of getting those enzymes into our digestive tract. Now remember, our pancreas has both an endocrine function as well as an exocrine function. We covered the endocrine function of the pancreas last semester. We talked about the insulin and glucagon that are released from the pancreas to control our blood sugar levels. This semester, we're focusing more on the exocrine function and how the enzymes that are released through the pancreas aid in digestion. There are 3 parts to the pancreas: the head, the body, and the tail, and the pancreas as a whole is divided into lobules, much like the liver. So the pancreatic duct is how these secretions get into the duodenum. The pancreatic juice that is secreted is mostly water and ions, all the enzymes, as well as buffers. Remember, this substance, the chyme that's coming in from the pylorus of the stomach, is very, very acidic. So one of the main first functions that needs to happen in the duodenum is that this chyme needs to be neutralized. And so that is one of the functions of our pancreatic juices. About 1 quart or so of pancreatic juice is produced each day. There's also an accessory pancreatic duct called the Santorini duct. This is a branch from the pancreatic duct. It empties separately into the duodenum. It's not as high functioning. In fact, almost all of us don't even have one of these, but it's just kind of like a backup duct just in case the hepatopancreatic sphincter is damaged in some way. So the pancreatic tissue itself is dominated by the pancreatic acini. The acinar cells are the ones that are producing and secreting the pancreatic enzymes. The islet cells have the endocrine function of releasing insulin and glucagon into the blood. So that's one of the big differences here. If we think about, and you can see this zoomed in view here of the pancreas, you can see the islet cells and the acinar cells. The islet cells are typically around a capillary because they're secreting insulin and glucagon directly into the bloodstream. The acinar cells open into the lumen of our pancreas where the pancreatic duct is, and that is for secretion of these enzymes and buffers, which will go through the pancreatic duct and into our duodenum to mix with the chyme. And then this top view here in this picture shows you how that pancreas is nestled into the duodenum and its relationship to the liver and gallbladder. So let's talk about some of these pancreatic enzymes. I mentioned amylase before when we talked about salivary amylase, that carbohydrate enzyme breaking down starch into smaller disaccharides. Well, pancreatic alpha amylase is another carbohydrate. It's breaking down certain starches. It's almost identical to salivary amylase, just works at a slightly different pH because the pH in our saliva is different than the pH in our duodenum. There's also pancreatic lipase. Pancreatic lipase breaks down certain lipids and it releases the products that can easily be absorbed, so smaller lipid droplets. You also have nucleases, which are going to help break down RNA and DNA, and then the proteolytic enzymes breaking down proteins into dipeptides, tripeptides, and amino acids themselves. They're secreted typically as inactive proenzymes, and then they become activated when they are in the solution in the duodenum. So the active forms are named trypsin, chymotrypsin, carboxypeptidase, and elastase. Those are the specific enzymes that are activated in the duodenum. This is just a list of those major pancreatic enzymes, and you can pause the video here, go back and review this section. We're going to keep moving forward, talking about some of the disorders of our digestive system. For example, in our oral cavity, periodontal disease is prevalent. It's the most common cause for tooth loss. This generally occurs later in life when the dental plaque is just building up between the gums and the teeth. Typically, this is resulting from gingivitis, which is inflammation of the gums caused by bacterial activity, tooth decay, as well as the breakdown of those periodontal ligaments and the surrounding bones. So there's the periodontal disease. You can see the erosion of the gums and the exposure of that root of the tooth. That looks very painful. In our salivary glands, mumps is a disorder that could affect the salivary glands. It most often affects the parotid salivary gland up here near the masseter muscle. It can also affect other organs like the gonads, the testes and ovaries, or the meninges. So it typically occurs around 5 to 9 months of age. Most of us don't even know much about this because we've been vaccinated through the MMR vaccine, which is required for public school attendance, typically given to infants under 2 years old. There's mumps of the parotid. In the esophagus, there's esophagitis. This is simply an inflammation of the esophagus. This is typically caused through something like gastroesophageal reflux, where the acid in the stomach is coming up through that cardiac sphincter and damaging the epithelium of the esophagus. It is could also be caused by a smooth muscle issue with that cardiac sphincter itself. So when that stomach acid backs up into the esophagus, it could cause this inflammation and the erosion of the esophagus itself. There is esophagitis. It's very inflamed, so you can tell the redness in there. It should not be red. It should just be a nice soft pink. With the liver, we have hepatitis, which is simply just a generic term for inflammation of the liver. This can be caused by alcohol abuse, drugs, or even infections. Cirrhosis is a version of hepatitis that's characterized by the degeneration of those liver cells, and it's replaced with scar tissue. So basically, the liver cells themselves are becoming non-functioning, and it's replaced by stiff scar tissue that's not going to be able to filter or regulate like the liver cells do. Viral hepatitis A, B, and C will destroy the liver cells. This can cause an inflamed, very tender liver, a very high fever, very painful and uncomfortable. Jaundice can result as the buildup of bilirubin causes the yellowing of skin and eyes, and this would be because the liver is no longer recycling that bile out of the blood and back into the gallbladder. So there is, and this lecture didn't really address this very well, but there is a cycle of bile that occurs. So if you can imagine, the bile is secreted into the duodenum, it emulsifies the lipids, and then it just continues on in the digestive tract, all this bile. So at some point, that bile is reabsorbed back into the blood, right? This mostly happens in the distal and in the ileum, as well as part of the large intestine. So when that enterohepatic circulation of bile occurs, that bile is being taken back up by the large intestine or small intestine and routed through the hepatic portal system, because remember, all veins from the digestive tract go to the hepatic portal system, and then that bile is removed back from the blood and stuck back in the gallbladder. So it's basically recycled. It's called the enterohepatic circulation of bile, and that's what happens. So when the liver can no longer reabsorb the bile back from the blood, the bile builds up in our bloodstream and collects in our tissues, causing that yellowing that we know as jaundice. This is a cirrhotic liver, all that scar tissue building up as little nodules. There's also gallstones that can exhibit, typically this is when insoluble materials and salts basically result when our bile becomes too concentrated. So if you have a very fatty diet and bile is continually being secreted from the liver and not stored in the gallbladder, then the bile that is in the gallbladder can become super concentrated. Because remember, that's what happens when bile is stored. It's going to become concentrated. So that bile that's kind of left sitting there in the gallbladder for a while super concentrates, kind of hyper concentrates itself and forms these stones. They're almost like little marbles or rocks. And these small stones get pushed out eventually through the bile ducts and can be very, very painful. Some of them, if they're small enough, you would never even know that they're being secreted, but the large ones get stuck and can be very painful. There's some examples of gallstones. Again, they look like little rocks. I had the opportunity to go and see a cadaver dissection. I may have spoken to some of you about it before, but they had a gallbladder on the table, and it literally felt like a coin purse. It was like this little bag with like change in it. It was weird. It was a gallbladder with gallstones in it. There's also cholecystitis. This is the irritation and damage to the gallbladder caused by gallstones. So the gallstones can actually cause a blockage in that cystic duct or in the common bile duct. And typically the removal of the gallbladder is what has to happen. The surgery has no effect on bile production because remember, it's the liver that creates the bile and secretes it into the duodenum. So people that can live a totally normal life without a gallbladder, you just won't have much of a backup plan in case you have a large amount of fat all at one time. So you might have a little bit of gastrointestinal discomfort from that. Gastritis is a general term for the inflammation of the membrane lining the stomach. This could be from ingesting drugs like aspirin or alcohol. This could also be caused by severe stress, bacterial infection, or eating or ingesting dangerous chemicals. So think about those times when you eat something that just doesn't let your stomach settle. Might cause some stomach pain or discomfort, or maybe some diarrhea or upset bowel. That's gastritis. It's just a general term. Your stomach can also develop what's called a peptic ulcer. This forms when those gastric enzymes and acids basically eat away at the lining of the stomach or the duodenum. A gastric ulcer is in the stomach wall, a duodenal ulcer is in the duodenum wall. There's also an infection caused by the Helicobacter pylori that's responsible for the majority of peptic ulcers. The treatment includes Tagamet, which is it's a drug that inhibits acid production, or antibiotics in the instance of H. pylori infections. So there's a gastric ulcer. It's literally like a sore on the lining of the stomach, and you can imagine it'd be very sensitive and painful. Pancreatitis is the inflammation of the pancreas. It can be due to some type of blocked duct, a viral infection, or toxic drugs, including alcohol. If the pancreatic cells are injured, those lysosomes would be activated, and the digestive enzymes can be activated as well and released within those cells to try to kind of treat itself. And about 1/8 of all of these cases, death can occur because those digestive enzymes don't stop, and those enzymes literally destroy the pancreas. There is pancreatitis. In the small intestine, enteritis can occur. This is the inflammation of the intestine itself, causes diarrhea. This is typically happens with parasite infections like Giardia lamblia. That's like a protozoa that lives in like dirty water. Dysentery, right? The inflammation of the large and small intestine, producing diarrhea, bloody stool, right? Mucousy stool, etc. There's the good old Giardia lamblia. Gastroenteritis is the inflammation of the stomach and intestines. This is typically because of a bacteria or pathogenic infection in areas where there's poor sanitation, low water quality. Gastroenteritis could result. And again, it's the typical diarrhea and upset stomach effects, like kind of like a food poisoning type of effect. Colitis is the inflammation of the large intestine. It's usually associated with one extreme or the other, either constipation or diarrhea. Diarrhea from maybe too much fluid or from compromised absorption abilities, right? Constipation would be when you have those really dry, hard feces, and that's because there's too much water reabsorption because of the slow-moving feces through your digestive tract. Unfortunately, colorectal cancer is also an issue aside from skin cancers. This is the third most common cancer in the United States. It affects men and women, typically over the age of 50. And one of the main risk factors is an environmental, right? Having a diet that's rich in animal fat and low in fiber has been linked to colon cancer. So make sure you're eating or drinking your fiber. Inherited disorders can also promote the formation of these tumors in the colon. They typically begin as polyps and then grow from there. So prognosis is very important, and that's why colonoscopies are recommended for individuals over 50. There's a colonoscopy. And there's your last slide with the last 3 review questions of this chapter. So please let me know if you have any questions on this material. And that concludes chapter 22. Have a super awesome day. Bye.